Wow, it's been a year, 12 months, and here we are again. Ramadan is upon us, and we've got Ramadan Radio once again live and kicking. So it's been quite a year, hasn't it? COVID-19, pandemic, schools closures, Brexit happening, and lots of, no traveling, no holidays, schools closed, schools opened, and then vaccinations coming in, rollouts, etc. So what do we talk about? It's so much that's been happening over the last 12 months, if not more. But we are here again, and we will again be bringing you on this show on Sundays at 12 p.m. an array of wonderful guests and speakers who will be talking to us about various health matters. And today we've got a gem as well, who I will be introducing to you shortly. But before we introduce our guest, you are listening to Ramadan Radio 87.9 FM. And we would really like you to interact, really like you to come in, ask questions, offer suggestions, give your views, your opinions, which may turn into questions for our guest. And there's various ways you can do that. You can call us on our landline at the radio station, which is 0116 248 2086. You may WhatsApp us or text us on 0774 8855 or email us at info@ramadan.fm. So I'll keep reminding throughout the show how different modes of you contacting us. But keep listening, and I'm sure and I hope that the discussion and the talk that we will have today will be of relevance and will be of help, because this is what Ramadan radio is all about. It's making it meaningful for all you listeners out there. So I'm going to go to my guest. I'm going to introduce him. His name is Dr. Hisham Haq. And I actually don't know where to start, because he's got a long list of credentials. So I'm just going to try to keep it as summarize it rather, because so that we can hear him rather than me speaking and introducing everything that he does. So Dr. Hisham Haq is a primary care physician, and he's also a treasurer for LMC, and also a treasurer for the GP Survival and National GP Group. He's been a GP for over 10 years, or longer. I actually think it's longer than that, Hisham. And he has an interest in digital solutions and workforce development. So this is something that he sent me, but I'm also aware that Hisham, I'm going to take the liberty of calling him Hisham rather than Dr. Haq, because I know Hisham quite well. He's like a brother of mine. So Hisham is also the former, only recently he stepped down as the social secretary for APNE, which is the Association of Pakistani Physicians of Northern Europe. And he's just been inducted as the General Practitioner Lead for Mental Health in BPPA, which is the British Pakistani Psychiatric Association. So he's very well sought after. So without much further ado, Assalamu alaikum and welcome, Hisham.
Wa alaikum assalam, Shahid bhai. Thank you very much for inviting me today.
You are more than
to all of our listeners.
You are more than welcome, Hisham, and it's a pleasure to have you here as always. And what I'm going to do is, I can talk all day, but I'm going to keep quiet for a little while, and I'm just going to open up a very open-ended question to you. And what I'm going to do is just ask you, you are a general practitioner, meaning that you work in primary care and in Leicester. And what I'm going to do is just ask you if you can give us a few minutes and just give us a bit of experience and a bit of a flavor as to what you've experienced over the last 12 months, particularly in relation to the pandemic, or in relation to the pandemic rather, COVID-19, etc., the journey and how it's been for you as a GP.
It's how long have we got is the first thing which comes to mind. We were always prepared for a pandemic. We knew that we would get a pandemic of some sort, and the government has always had a plan to deal with any pandemic. But the sort of pandemic that we were predicting was a flu pandemic, and most of our things or training was geared towards how we would handle the flu. The last time that we activated that training or planning was somewhere around about 2008, when we thought that we would get a swine flu, because there was a big outbreak in in Mexico, and 500,000 people died in Mexico, and we thought that we would get something quite similar. And at that time, we had Tamiflu, which we were dishing out, and we had mobile centers where we were assessing people. After that, we've been looking out for the SARS-CoV virus, because we had the Middle Eastern SARS virus. So we had some cases of severe respiratory illness that we read about, but they were not very infectious and they were very well contained. And they started off in the Southeast Asian countries, in Thailand, and those countries had put up some very good surveillance systems as a consequence of that. And we had some cases in the Middle East, and when people were going to Hajj, and we were aware of them. But when this pandemic hit, it caught us completely off guard. The severity and the ferocity with which it spread all across was something which we were not prepared for. It caught us off guard. Not only that, but we did not have any treatments for it either. So the treatments were very far behind, and it was like walking in the dark when it first hit. And if everyone remembers how it was at that time, when we were all sort of just in total lockdown, flights were stopped globally. And everyone was told to stay at home. And I rather unfortunately ended up at my local hospital, which is Glenfield Hospital. It's a center within the East Midlands where there's a lot of specialization for respiratory illness. And I went there merely to drop off some bloods for a patient of mine for whom I wanted some urgent bloods. And this was right at the very start of the pandemic. And I went inside, waltzed in, no mask, no nothing. And I was met with total silent corridor, people in full gear, PPEs, and then casualties coming in with air chambers wrapped all around, high flow oxygen masks. And there were two of those casualties which arrived. And when they arrived, they had to close the corridors down because even someone passing nearby any of those casualties could potentially get infected. And that then really brought home the ferocity of what we were doing at that point in time. From a primary care perspective, we went on to total non-face-to-face consultations. So in my practice in particular, if anyone wanted to be seen, we would prefer to see them face-to-face and only do a telephone consultation as a last resort. And now the model is completely being flipped over. We also had introduction of several technologies. We had participated in various endeavors where we've looked at technology solutions, and the red tape around those technology solutions became much shorter very quickly. So that was one of the positives which came out, that the health services is now much more geared up towards the future and is much more geared up in terms of being proactive and preparing better than it was ever before. In your introduction, you mentioned about lots of things which has happened. So we had the Brexit, we had the vaccination programs, we had the rollout, we have skepticism about vaccinations, we've had the clap for carers, we've had lots of things which have happened. But it's been like one big roller coaster ride. That's the only way to describe it.
Indeed, and I think the last part, you've just summed it up really, a roller coaster ride. That's what it's been like, indeed. And during, unfortunately, this roller coaster ride, we've lost a lot of people. We've lost a lot of loved ones. And but from your perspective, Hisham, where are we at the moment? How are things? Do you feel going forward from March, April last year, where we had this huge surge, the lockdown and the surge and the peak of individuals not only becoming infected with the coronavirus, but we had, a huge influx of admissions into hospitals, which obviously we saw in the second peak as well. So how's that been for you from a GP perspective, Hisham?
It's been very frightening to begin with. So where people, if they were touched with corona, would have meant instant death, we're now in a situation where we're encouraging vaccination uptake, and the UK is a world leader when it comes up to vaccination protection, and vaccination uptake as well. So we lead from a population perspective in terms of vaccination offered and vaccination accepted ratio, and that's very. Most of the countries in the world are quite envious of how we actually managed to attain such good uptake, and that's basically because of the strength of the family physician playing a central role within this sphere. We went on very quickly from not knowing exactly what to do about the whole scenario to now having at least some forms of treatment. A lot of research has been published across the world. Even when the pandemic hit us, there were at least about 2,000 papers which came off mainly from the Chinese experience about what sort of treatments they were doing or they were not doing, which were either helpful or not helpful in many circumstances. And then we came across dexamethasone as being a life-saving drug of some sort. And in addition to that, we've then gone on to to taking convalescent plasma, where someone who had recovered, we would take the protective material from their blood and inject it into someone if they were very unwell and see how they would do. And then we went from knowing that that would be a sure shot, something which would work, to now knowing that actually that doesn't really work really well. Now we've come on to a new treatment where steroid inhaled spray is actually the next one, which has actually been shown to do a lot of promise. And we've picked up, and we now know a lot more within this last year than we did at the start of the pandemic. So on the basis of that, I would say that we are in a much better position. Our mortality rate has also fallen from 700, 800 or 900 or to 1,000 to now less than 100, somewhere touching less than 50 on most days. So we're in a much better position than we were compared to last year. We have to open the economy up. We have to get going. We have to start working. Everyone's sort of very keen to get moving as well. Now, there lies the fear where when we start meeting each other again, what is that going to do for us? Then there's the variants which come down. So the Kent variant is incredibly infectious, and unfortunately, the UK has been infamous for transmitting this virus across the world. But now we're having some other variants and mutations, which is part of the virus's normal life cycle. Normally where it would work is that as long as it kept mutating, it would actually mutate itself to death, whereas this one is actually mutating itself to becoming even more vicious at times. So it tends to wax and wane a bit, where majority of the mutations are less severe. Some of these mutations are actually becoming quite serious. But once again, the UK has got a very good surveillance system where we tend to pick up any of these virus strains. And we've got some novel ways of picking up some of these strains as well. One of them being that we would pick up virus cases from sewage waters in terms of trying to see how many cases there are or how many different variants we can probably build up. So there's a lot of work which is being done by Public Health England, and we're leading when it comes up to population disease management, and we're looking forward to it as being a bygone memory at some point as well. I was quite hopeful a few months back that this would actually get better, but these variants which are now becoming, and now there's a double variant which is now predominantly coming in from India, that variant might actually carries quite significant risks for our vaccination program or for our overall health, because sometimes it can spread like wildfire. With us being vaccinated, we've got a lot of protection in terms of stopping it, and these vaccinations have been shown that once you're vaccinated, at least your risk factors for becoming seriously unwell are actually diminished quite a bit. In fact, in some accounts have said that there's a 100% chance that if you did catch the coronavirus, you would not be as severely infected. But the new variants might actually be resistant to that. So we don't really know is the big answer. But what we're hoping for is it's never going to be as bad as it was at this time last year.
Mm-hmm. Thank you. No, we'll come to the variants in a moment again. I think that's really important, especially for our listeners to get a good understanding of what it actually means, and in very simple terms, what it means by variant and what it means by double variant. So we'll come back to that in a moment. But in the meantime, I just want to remind our listeners that you are listening to Ramadan Radio, 87.9 FM, and please contact us. Any questions, any suggestions, any views, you can text us on 0774 8855 You may email us on info@ramadan.fm. If you want to call and talk to our guest, if you want to say anything, express any views, you can ring us on 0116 4822 086. We are also live streaming on YouTube and also on Facebook as well. And Twitter. So visit us so you can see we are extremely multimedia tacky. So we've got an excellent producer who actually looks after us and makes sure who that we're out there. So please do contact. So Hisham, you've just mentioned the variant. Please, for our viewers to understand, what does it mean by variant when we say that we are getting variants? And you've just mentioned the word double variant coming from another part of the world, South Asia, India in this case. So if you can just break that down and just explain in so our viewers can understand what that means.
So essentially speaking, virus is basically a very simple structure, but and when I started off studying medicine, we were told quite clearly within the textbooks that human virus is a human virus and an animal virus is an animal virus, and humans don't get animal viruses and my viruses don't get human viruses. Now that seems to have changed somewhat since I qualified a few years ago now. And we're now finding that these viruses can actually jump on from animals to humans. And we had things like bird flu, we had viruses like the swine flu, and then we've got this new variant, which is SARS-CoV, which they've been hypothesizing has jumped from a bat to a pangolin and from a pangolin to human beings, which they felt was the most plausible explanation that they've come out with as to where they found it. And the reason why they've come up with these variants is because they've been studying these viruses within the animal population, and they have seen that this virus has got genetic material which comes from there. Now, genetic material is basically the key word over here. Now, genetic material is, so if you look at sort of like a virus, and everyone's probably seen the pictures of the COVID virus, where you can see that it's got sort of like a center and it's got spikes coming out of it. And then on the inside of that, of the circle, there's another genetic code. Now, the genetic code, if you were to sort of like stretch it out like a string, it's got sort of multicolors over there as well. And every time that the virus divides, it tends to change its color over there as well. And those color changing then changes the shape of the proteins which are out there. Now, when those proteins, shape of the proteins changes, it actually makes it less possible for it to enter into the human cell. And when it enters into the human, when it has difficulty in entering into the human cell, then it's got it's more easier for it to then either cause problems or not cause problems. So what happens is that when the virus mutates, this genetic material keeps on changing all the time because the body is partially attacking it and it's attacking itself. And that's the reason why we built up resistance against viruses over a period of time. An example is that we have the flu vaccine, which is given every year, but not everyone wants to get the flu vaccine because some people are stronger towards it, some people are a little bit more resistant towards it, and some people tend to get easily anything which comes through the door. And the reason is because we have resistance and the virus has variants. And depending upon how resistant you are, whether you've got good resistance or low resistance, and how virulent this virus is, which means can it easily get into your body or can it not easily get into your body, that will then decide. If I were to give you a historical case, which is quite interesting, it's to do with the Aztec Empire or the Inca Empire. When the Spanish, they invaded South America, these people, they were living in ships. They were coming from Europe. Their conditions were sort of like very cosmopolitan at that time, very squalid at that time, and there was a lot of virulence within that community, and that virulence was a lot stronger within the community of the Spanish soldiers who went down over there as well. Whereas the Aztecs or the Incas, they were living in open environments. They were very holistic, and they were not very they were not very strong in terms of having faced off with these influenza viruses. And when the population got infected with influenza, that nearly wiped them out, and that is why the Spanish were quite easily able to hold off or conquer a whole population or a whole continent, compared to if they were just going inside fighting down one by one. And that's what the virus does is the virus keeps on changing, and it seems to have various different types. And depending upon the type of virus, then it changes. The SARS-CoV virus is called a SARS-CoV-2, which means that the first one, which I talked about earlier, which happened in the Middle Eastern virus, and that was SARS-CoV-1 virus, which happened maybe up to about 6 or 7 years ago, when we first came across some of these sort of cases, and that's now become a lot more virulent. But so normal history with these viruses is as they start to keep dividing, they get weaker. But this particular virus seems to be can change shape, and when we talked about the double virulence, we've gone into a second phase of lockdown, and that happened because we had this virus strain which we called as a Kent variant, because we first detected it in Kent. And this virus was spreading a lot more faster. So where we would say that the last previous virus would probably have infected every 8 people if it met in a room, this virus was affecting all 13 or 15 people. And those 15 or 30 people were able to transmit it much more quickly as well. So this virus, which is essentially very simple structure, the spike shapes change, and when the spike shapes change, then it was able to spread a lot more quicker. It was able to penetrate the body a lot more quicker. It needed less numbers in order to be able to establish itself into your lungs or your respiratory passage, compared to what it would have taken if you were if compared to the previous variants. So a double variant basically means the two bad things. So one of them was how easily it could spread. Number two could probably be how ill it could make you feel. And Brazil was having quite a tough time, and Brazil had a few variants, and then South Africa had a few variants. And now those two variants where it was spreading or it was causing a lot of illness, we found those two variants now within this new cohort of patients in India. And we found about 70 odd cases of that same variant now in the UK as well. So there's no doubt that immigration or migration or movement of human beings is transmitting these viruses much more quickly compared to what it is previously.
Thank you very much, Hisham, for that very comprehensive explanation of variants and double variants and what we're looking at, and a little bit of understanding behind the science behind what variants actually means. I'm going to go back to the very basics, Hisham, and this is something that we've been talking about right from day one. And individuals and people, be they from the healthcare professional, be they not from the healthcare profession, can be very laissez-faire about it, or be very casual about it. And what I'm going to say is just go back to the basics, and can you just explain why it's really, really important to go back to the face, space, and hands thing? And we're basically talking about masks, the 2 meter distance, and making sure that we wash our hands. Because what we don't want to do is, we don't want to forget the basics, do we? And how much of a difference that makes. So with each one, we can talk about the mask and why that is important, why it's important that we continue to wash our hands, and why it's important that we continue to maintain the proximity that we're supposed to, the distance we're supposed to keep. So from a doctor's perspective, Hisham, so that our listeners can understand, why is that going to remain the mainstay of prevention, or the number one preventative measure, if you like?
So there's the reason for that is that you mentioned three things, and there's a fourth one now, which is sort of like fresh air as well, which has been introduced. But I'll start off with them one by one. So when they talk about face, what we found initially was that we did not recommend the face masks in the UK. And when we looked at it, there was emerging evidence coming out that, look, countries where they were actually wearing face masks were actually making sure that they were not having as many cases as we were in the UK, because the UK was particularly hard hit to begin with. And by the time that we imposed the lockdown, the virus had spread in all parts of the country. We couldn't really sort of like put any measures in place. It initially started down with London, but then it really spread like wildfire across the UK. And it was basically the touch. So when you were touching surfaces, for example, you were touching a door handle, and someone prior to you had either got some infection on their hand and they touched the door handle, then you were easily taking that in. And then when you were either touching your face or your nose, or you were eating, you could easily transmit that virus into yourselves. And that's the reason why we were falling ill. And the other thing to do with face was to do with the face mask as well. So if anyone was ill or unwell, and if they were not covering their face properly, or however they were trying to cover it, they would probably still be ejecting a lot of virus load over there as well into that surrounding contaminating spaces, where the virus could live for anything up to a few hours to maybe even up to about a day. And anyone coming into that environment later on would probably have been able to pick up the infection and take it across to them to other places, or into their own house, or into their own workplaces, or to any other community spaces like any shops or anywhere else. So that's the reason why face was introduced, so that people do not sort of like cough, which spreads quite widely, and they can actually contain something within the face mask, or when they were there, then they weren't really accidentally touching or contaminating themselves. So that's to do with face. Space basically stands for 2 meters apart, and what that also was meaning was, when they've done the study in terms of when you do tend to cough or sneeze, how far do you eject the aerosol? So there's a lot of, say, give you the example of sneeze, that would probably be a very good one. When you were to sneeze, then you would probably be ejecting a lot of secretions outside, and a lot of that secretion can actually travel as far as up to about 20 feet. Majority of it would probably stop within about a meter or so, but then there could probably be some lighter or smaller elements which could then travel much further. And the space element was there so that if we are coughing, then we tend to protect the next person so that we're not able to transmit as much as further. Uh, the third thing that you talked about was face, space, and
Hands.
hands. So hands was really important because this virus is actually when we talk about that round circle is got a fat layer around it, and because it's got a fat layer around it, if we were to use soap would disintegrate it very, very quickly, which is why the 20-second hand washing is very much there. And that's been promoted and that's been shown multiple times that just simple acts like hand washing with either alcohol gel or either using soap by itself, and there are certain other methods which are chemicals which are now available, which are not alcohol based, but which can probably help in terms of getting rid or disintegrating the virus. And the fourth thing is now, which is being talked about, is fresh air, because what they found is that if you are all friends or family gathering within a closed room, and if you've got a ventilation open where there's some air coming in and out, you've got a better chance of not being able to spread as much. Because what we learned initially was that you might actually become ill, you will not show symptoms, but you could still be spreading the virus to people around you, and you would only fall ill after maybe 3 days to about 7 days. And that was what was really concerning about this virus, that someone like me would probably pick up the virus from, say, a friend or a patient who came down to see me, and I would probably bring it into my house and I would not know about it. And if I'm sitting with my friends, I would probably spread the virus to them without even realizing or having a chance to warn them that, look, something happened. So fresh air was a fourth thing which has also been introduced now, where that can actually help to reduce chances of spread to each other. And what we must remember is that even though that we're getting vaccinated now, we can still fall ill.
Yeah, and I think what you just said there is really important for our viewers to really understand. I mean, and that's why probably part of the government's guidelines are mapped to slowly and gradually move towards normality is how we can meet our extra people from outside the family in our gardens. And probably that's more in relation to what you just said, Hisham, about fresh air and how we maintain that. And I suppose with the mask also, it's really important also, just to add what Hisham has said, is that how it protects other people. So when we put the mask on, as well as protecting ourselves, we are actually more protecting the other person. And if two people who are talking to one another do both have masks on, it almost reduces the transmission rates almost up to about 90-95%. So that's how much protected one can be. And yeah, it's one of the things that we are really, really looking at the moment, Hisham, is that where we go next from here. But having said that, you've just mentioned a moment ago, we've just got less than 2 minutes before we go on our break. So just if you can just highlight, you mentioned that even if you've got the vaccine, and we will talk a little bit about vaccines, although we'll have another separate show for that, but just saying that even individuals who are vaccinated can still carry the disease and can still pass it on, the infection. So we've just got about under 1.5 minutes. So if you can quickly touch on that, what you actually mean by that, Hisham.
So vaccines are being it's something which has actually been tried for centuries now. And the earliest example for vaccination was being used by the Ottoman courts. And there was an English physician whose wife observed that the Ottoman physicians were treating smallpox by having a variance where they would actually expose some cows to this thing, and then they would use those scabs and rub it onto to their courtiers, and that would then give them immunity of some sort. And she brought the same technology back to the UK, and it wasn't very widely accepted at that point in time. But that's the crudest form of vaccination, and it's a lot more sophisticated now. It's a lot more scientific. And this new technology which is being used for the Pfizer and the Moderna seems to be much better than some of the traditional methods of vaccine production as well. And it's been fast-tracked, and it's showing a lot of promise at present compared to many of the other vaccine products which are available right now. So we must remember that there are multiple.
Let me just stop you right there, because I'm very conscious that we are counting down to our break. So if we can just continue, just hold that discussion there, and we will come back, and we will take a break, and we will continue with this discussion just in relation to the vaccine. So to our listeners out there, we will be back shortly. See you on the other side. Assalamu alaikum and welcome back to Ramadan Radio 87.9 FM. I'm your host, Dr. Shahid Latif, and we've got another excellent program today. And today we're talking about COVID-19, the pandemic, and primary care, its impact, the management and treatment. And we've got Dr. Hisham Haq, who has been talking about his experience as a GP and has been providing us with knowledge about various factors around COVID-19 and what's been happening and what we ought to do. So before we go back to Hisham, just a reminder that we would love to hear from you. And you can call us in to give your views, ask any questions, ask our guest any questions. So our number is 0116 4822 086. You can also text us if you don't want to talk to us directly. So you can WhatsApp or text us on 0774 8855 or email us on info@ramadan.fm. You can also follow us because we are live streaming on YouTube and or Facebook as Ramadan FM, and we are also on Twitter. So tweet away. But here we are. So going back to Hisham, so just continuing with the discussion, Hisham, a lot of people do tend to ask, and as a doctor, obviously, it might come as a very straightforward question to you, but we do often get questions from lots of people in the community asking, how comes the coronavirus isn't as bad in, let's okay, it started off in China. How come it's not as bad in China anymore? How comes when it was really at its peak, it was really, well settled and established, not very well established, and it was people were managing it much better in low and middle income countries, the African countries, the South Asian countries where the healthcare isn't as good, but like in Western countries like the UK, like France, like Italy, like the US, why has it peaked? Why have so many people died here and less people there? So what would be your response to that, Hisham?
That's not a very simple question to answer. So, but I'll try and break it down for you. So you talked about China. Now, what we looked at China was our test case, and the world was about 3 months behind whatever China was happening in China. And even in China, so they imposed a total lockdown, and they started off at Wuhan, but then it very quickly spread across China as well. And the other thing which the Chinese did was that because it's a communist country, they were able to impact decisions on a bigger scale, on a wider scale, much more quickly, which basically meant that laws such as liberty, free movement, free speech, they could be curbed. And that gave them an absolute tool to use in these circumstances, and it proved quite useful for them. Whereas over here in the UK, we had to balance things out. So the Chinese were having sort of like tracking apps, which were sort of like all the rage over there, and they could track anyone, and they could track and backtrack and find out who the person was, who they came in contact with, without any consent from anyone. So their surveillance system was already very strong, and it became even stronger, and they invested quite heavily into it. Whereas over here, because of civil liberty laws, we were a little bit less lax in terms of being able to control and to monitor as closely, because that's basically something that we don't do as a country or as a nation. That's something which is not acceptable to us, where we can have Big Brother tapping into us or monitoring each and every movement of that we tend to have. So that's one problem. The other problem, if you talked about other countries which were much poorer, who were able to have much better outcomes. So if you take a look of some examples, so Kerala in particular was one example, where the health minister, as soon as she read some of these cases, she imposed some curbs on the ports, and they were able to localize and close down or clamp down on some of the cases much quicker. Now, the consequence of that was that people didn't actually appreciate what they were doing and what thinking was going behind it, and how quickly some of these governments were working, and they didn't actually appreciate what they had managed to avert. Now, because of that, their first spikes were not too bad compared to what the UK had experienced, but then their second waves and then their third waves were much worse off than compared to what we're doing in the UK. An example of that is that we'll talk about death rate, that when we started off, our death rate was touching nearly about 1,000. In the second wave, it was touching somewhere around about 600 to 700. In the third wave, it's now come down to about tens. So anything less than about 50 or less than 100 is basically where we stand right now. And the consequence of that is that we kept on slowly and gradually working on the population, and we cutting down on those sort of things. The other problem with the so it's not entirely true that we're very different. I think it's just dependent upon the approach that we had. We practice evidence-based medicine, so if we had to practice or try out anything else, we were trying. It was more of an evidence-based approach, and we've had some good results now in terms of some of the trials where dexamethasone has come out. Now there's another steroid inhaled spray has been coming up as a new treatment, which can actually reduce the time of serious illness down to about 3 days. That's a new form of treatment which is now sort of like being approved. And those have come across because things have happened, but they've happened on a slow and steady pace, and with continuous work happening in the background. Initially, I think the people who were affected, who've died a lot more, have been people who are coming from the BAME population, which means that Black, Asian, ethnic minority groups were affected a lot more disproportionately. And it could well be that maybe there are multiple explanations from it. Genetics would probably be one explanation for it. The other explanation would probably be that they were much older, living much longer. And if you want to take an example, we will talk about the life expectancy in Pakistan, which for a male was about 68, and over here, if they were living, would probably be anywhere up to about 80. So although they live better and they live longer in the UK, and they die younger in Pakistan, coming from same genetic background, but the flip side was that these people, when they were living longer, they had many more illnesses. And unless they were protecting themselves fully with vaccinations, then their chances of falling ill would probably become a lot worse. Attitude would also be defining it. So having a fatalistic attitude, where they would leave everything to the will of Allah without taking any precautions or doing anything proactively for themselves or for the people around them, saying, "Oh, Allah ki marzi thi," and dismissing it is also another problem. Which I've seen in practice. There was a very senior cleric who came into my practice. He's one of my patients, and I talked to him about vaccination, and he was very rigid in his views and not wanting to accept it. And his medical history was also as such, where his compliance with many of his treatments would probably be very difficult for me. But I think that would probably be an individual patient, an individual person. Whereas my approach to talking to most of the patients is that I always introduce myself more as a learned friend, where I know more about medicine, but I respect the fact that my patient is a specialist in himself, and that relationship allows us to have these conversations and move forwards much more easily and much more quickly.
No, thank you for that comprehensive response, Hisham. I'm just going to change the drift slightly and come back to primary care, GP land, and I'm going to talk about, or ask you rather, about the chronic conditions like diabetes, like hypertension, cardiovascular problems, like rheumatoid arthritis, and these chronic conditions. What's your experience been, Hisham, from various aspects? I suppose, for example, starting off about 12 months ago, virtual. Consultations, and what kind of impact it had. Moving forward, now you are seeing patients again. Is there any difference that you've experienced as a GP, how you are managing these chronic conditions?
Well, so primary care is free at the point of use in the UK, and it's probably one of the free countries, one of the last countries in the world where you don't actually have to have any transaction before you come and see a GP. So primary care is really the jewel in the crown of the NHS. And primary care is definitely the beating heart of this crown. Our patient contacts fell to negligible amounts when the pandemic hit, first of all, and people didn't want to either bother us or didn't want to disturb us, they didn't want to do anything with us. And we were also very distracted because we were dealing with a lot more telephone calls or more services at that point in time. There is no doubt that people have bothered us less. That means that there would probably be issues which were there in the population, which we haven't really been able to contact with. As an example, people think that the practices had shut their doors and they were not working, whereas the reality is that we've been working throughout the pandemic. We've been doing blood tests for people who needed to have their regular blood test doing. We've been seeing anyone whom we thought that we need to see. We've been referring everyone, and the cancer services have been going full flow. They have never stopped throughout the pandemic. Operative cases, things which are not life-threatening were delayed. Things like hernia operations, things like hip surgeries or knee surgeries. So yes, people have been delayed in terms of seeking that sort of help, but the services have continued. There were still at least about 16 million operations which were done last year. They're down from 20 million the year before. So before the pandemic hit, we were doing about 20 million last year. With the pandemic, with the whole load of the pandemic, we still managed to do about 16 million operations. So there is a lot of work still to be done, but we are now starting to come into the phase where we're starting to catch up. We've taken this time and the opportunity where we were having less patient contacts to actually make our systems better. And what we mean by making the system better is that most of the practices now in the country, they started off by having a team which was composed of doctors, nurses, and reception staff and the admin staff, to now having a much bigger workforce and a much more comprehensive workforce, where my practice has gone to having now a clinical pharmacist, towards having a physician assistant, and I've also now got something called as a social prescriber in place. So I've got 3 different roles now, which are there within the practice. And these 3 different roles have a lot of different responsibilities. The clinical pharmacist tends to look at medication, because most of the problems that we have in primary care seems to be sometimes with medications, where medications can cause more illness or injuries compared to if they're being managed a little bit too intensively. An example is that someone's having their blood pressure managed too well, and sometimes that can lead them to having side effects, and then so that's where you need a little bit of variance. Sometimes people tend to change, where when they started the medication they were okay, but as they've grown older with the medication for the last 5 years, 10 years, their renal function is going downhill, and that means that their kidney function would then their medications then need to be adjusted upwards or downwards because of their health now compared to what it was before. So there's no doubt that there's a lot of work which needs to be done, but this time and the technology and these increased practice numbers, which are going to happen in any case. So this is already part of a plan which was there beforehand, and it's just worked through during the pandemic as well. But it's allowed us to actually organize the practices a lot better as well, and that's the case for most practices up and down the country.
No, thank you. And would you like to give any advice, Hisham? We've just got 2 minutes left. Would you like to give any advice for individuals? I mean, we've got Ramadan upon us, and obviously people are fasting. And would you any advice in relation to, people worrying about COVID-19, diabetes, medication, fasting, etc.?
So I think the advice would definitely be in terms. So I remember when we had the talk last year, we were talking a lot more about GI side effects, and we were talking about how what people were eating and what they were doing was having an impact on their overall health, and how GI health and acid reflux would probably impact on them. And we talked about medications as to how they can vary the medications. So in general, most of the medications are usually once a day to be taken medication, where they are 3 times a day to be taken, as long as you're taking it twice a day as well. You've got some variation going on over there, which should be fine, because as long as you're taking it at the start and at the end, you're going to be fine. Injectable medications like insulin are supposed to be continued. Even though that you're fasting, you might still need to have that insulin going inside of you. Whereas we know that some insulins are long acting, which you only need to take once a day, because they're a 24-hour type. They are completely safe to be taken whenever. As well as the fact that it's established that because it's not giving you any nutrition, because it's not going through the oral route, you're fine to carry on with insulin type medications. In addition to that, I think you're supposed to lose weight during this month, and then making sure that you don't sort of put all that weight back on in a hurry is also very important. So the general advice in terms of Ramadan is very standardized in terms of, look, you're doing quite well, you're doing it for all the right reasons, and it's going to have positive benefits on you.
Hisham, I'm just going to stop you there, because we've got just under 30 seconds left for the show. And I just want to take this opportunity to say thank you, Hisham. And it's been wonderful having you on again, and I'm sure we will do the same again. And I'd like to say a big thank you to Dr. Hisham Haq. He has been our guest today on Ramadan Radio 87.9 FM. And that's it for today. And we will see you next Sunday at the same time. Assalamu alaikum.
Thank you very much for having me. Assalamu alaikum.